So I wanted to put this in the context of UK Biobank because we've learned a lot from thinking about how we make this resource available. And I think one of the things that we're struggling with, and I suspect you'll have to struggle with, is about this new model of building a resource from scratch that is intended to be available for all kinds of researchers to do all kinds of research on, and what the implications of that can be in terms of access. So the principles of access for UK Biobank are available to academic and commercial researchers for all types of health-related research in the public interest, with no preferential or exclusive access. I'm sure someone will come up to me afterwards and say, can we collaborate with you on UK Biobank? And no, you can't. It's your resource. This has been the most difficult concept to get across, and we still have not succeeded in it. That people only have to pay for the actual costs of accessing it, which are minimal of its data, not for the cost of setting it up. The biggest problem, of course, is around the depletable sample and around how you manage that when you're trying to build a resource, as I said at the beginning, for all kinds of researchers in all kinds of disease areas. If you're interested in coronary disease, then you can perhaps make sure you have the right samples for that, and you can make sure you have the right analyses done for that. But if you also want to deal with cancer, eye disease, dementia, how do you deal with the samples that people want assays for now, as compared with assays that you want in 10 years' time for other kinds of disease? And the only requirement is to publish the results and to return the kind of derived data to the resource. And the IP in UK Biobank is held by the researcher who's derived something from it. So we try to make it as simple as possible. To put that now in context, what is UK Biobank? 500,000 men and women aged 40 to 69 recruited between 2006 and 2010 from within the National Health Service. And I'll come on to the fact that it isn't really a National Health Service when you're trying to do this kind of cohort. We obtained general consent for all types of health-related research and for follow-up through all health and other kinds of health-related records, as well as for recontact for specific purposes. Lots of questions and measurements and biological samples stored for future assays, looking at ways in which to enhance large subsets of the participants and to do assays of the samples from all the participants. And importantly, the need to do repeat assessments in time, over time, not in everybody, but in subsets, to determine variation. And a very large number of people were involved in the design of UK Biobank. And then they handed over the work to the UK Biobank team to do it. And that split between the scientific drivers of what's to be done and then a kind of industrial process of getting it done has turned out to work really well. I put up here what samples we collected, about 50 mils of blood into lots of tubes, and then we added on saliva because the dental people were interested in saliva later on. We've got urine collection. The main point I want to make here is that despite collecting 50 mils of blood, there isn't enough. There isn't enough sample, there isn't enough different types of sample for all the things that different people in different disease areas are likely to do. And I think that's one of the biggest problems with building this resource. These kinds of resources, you're not doing it for one particular purpose, you're doing it for many purposes, many of which you don't know. Lots of questions were asked. At the beginning of UK Biobank, the plan was to do interview, and then there were so many questions that people wanted that it was going to take so long and be so costly that one of the computer guys said, well, why don't we just get them to do touchscreen? And everybody said, yeah, the people can't do that. But then, in fact, by using touchscreens, we were able to really lower the cost of collecting data. And in fact, many of the touchscreen questions that we incorporated in that baseline visit, we're now incorporating into web-based questionnaires. So again, one could do a lot of this probably without seeing the individuals. We did, once we started with a set of very standard, rather boring physical measures, the kind of things that you know you want to do. But then once the machine was working, that provided the opportunity to then think, well, can we get more information about very substantial subsets? And again, I think this is something that you'll probably be thinking about. Get the machine working, and then think about things to add on once the machine is working. And again, this was driven by the scientific community. So people who are interested in hearing in the MRC, the Medical Research Council Hearing Institute. People who are interested in vision. So Moorfields Hospital in London is an eye hospital. They've got a group of people saying, we want more stuff on eyes. So this was added into it. Nick Wareham's group in Cambridge from the MRC unit wanted stuff on fitness. And so that was added into very substantial subsets. And that engagement by the academic community in telling us what to do and then not having to do it was a fantastic incentive. So just thinking, not doing, wasn't too hard for these guys. But then they felt they were engaged in it. And some of them have really become engaged in it. They've embraced the whole concept that it is their resource. And here's an example. The Eye and Vision Consortium, they have their own website. You can go into this website. They've got loads of different research groups looking at different pieces of eye and vision research. They are driving the agenda. And from our point of view, that's great, because they're also taking data that is inaccessible to most of us around imaging and things like that, and turning it into information, which comes back into the resource and is then freely available for other researchers. Many other enhancements have been driven by other academic groups. So web-based assessments of diet, and we're currently doing cognitive function. We've done 100,000 by sending out an email and having a web-based questionnaire on cognitive function. We're now doing repeats in them. Mailing out wrist-worn accelerometers and getting those from 100,000. Interestingly, during the period where we've been mailing out and asking if people would wear them, the proportion who've agreed to wear them has increased. We're building a community where people are more and more engaged in building this resource. Biobanking, genotyping all 500,000 with an array with 800,000 markers on it. Doing a standard panel of assays, and this I think is part of the solution for access to sample. Turn sample into data, and then it's really accessible to everybody. So try to think about what are all the different assays that lots of different researchers would want, and then do those really efficiently using low volume, low cost, high quality. And we're looking now at other panels to do infectious markers, immune markers. And then the plan to image 100,000 participants, which is currently going very well, and we would hope to image 100,000 participants. And again, that's another opportunity where this big subset's coming in to do even more enhancements. And one of the things we're going to do is put a cardiac monitor on them at the end of the visit, so they go away with a monitor on for a couple of weeks, mail it back to us, we download the data, and we get at the kinds of questions around that Dan raised around asymptomatic arrhythmias. And of course, people who are in the study want to know what you're doing, and they want to know, are they still wanting to be part of this project? So keeping them informed. And one of the best ways we've found to do that at low cost and scale is through email prompts. When something different is occurring, when something interestingly about the project is occurring, or something where we think people want to know that that's how it's being used, then we can send out prompts to people. And they can look on the website and get more information. And this is just a sort of microsite around the imaging. As I mentioned at the beginning, we don't have a single system. The UK is a devolved nation. We nearly lost Scotland. Unfortunately, we don't. But Scotland, Wales, and England all run different healthcare systems. Within each of those systems, the different kinds of data are held by different people. The death data, the cancer data, hospitalization data. The primary care data, which is probably the richest data because the primary care doctors implemented that earliest, all the data are held by commercial groups. There are about 3 companies that provide those services to general practices who are just like little shop owners, really. They're all independent suppliers to the NHS. And so we have to work with those suppliers to get all of these different data and put them together. But we can go beyond that, as been touched on, around other kinds of registry data, tax and benefits and payments data. And, of course, it's been commented on, direct to participants. So what can you see? If you go onto the website, you can look to see the death data. You can look to see the underlying cause. You can look and find out how many particular deaths there are. You can, if you're a registered researcher, you can then also seek and obtain cross-tabulations between various deaths and other conditions. At the beginning of UK Biobank, there was huge anxiety about the resource being used for purposes for which it wasn't set up, undue anxiety, and as a consequence, we put in a too complicated a system. We all accept that now, but we wanted to be careful at the beginning. So you had to register and then be checked that you were a bona fide researcher. You put in a preliminary application and that had to be approved. Then when that had been approved, you can put in a main application, then that had to be approved. And then that had to be signed off by an access subcommittee. And then you would have a material transfer agreement. So we're now looking at ways in which to streamline that process. Because particularly with the low risk applications around data, there's no need for all this complexity. And I would suggest that you avoid that mistake. The risks are low, the benefits of streamlining are high. The material transfer agreement is very straightforward, and I think that's very important. People have to use the data and samples only for the approved research project, but I think that's a bit restrictive around the use of data. It could restrict people's imagination once they've got the data. How far can you allow them to go without having to come back for more permissions? Restricting access to approved members of the research team. But that's a bit cumbersome in collaborative research. So again, how much flexibility can one build in? Publish the results, but then return the derived data to UK Biobank. So we're going to have to store all this derived data, and we're going to have to store it in a way that people can make sense of it in decades to come. That could be cumbersome and it could be costly. And what do we do if people breach the conditions? Well, if they're breaches of things that don't matter, should we do anything? Should we just change our material transfer agreement? But if they do matter, then I think we do have to have some penalties in place. And these are the kinds of things that we proposed in the material transfer agreement. So in conclusion, what are the issues? Well, we made the access process unduly complex, and we're now looking at streamlining that. I talked about the depletable sample. How does one deal with that? And I think the solution is get as much as you can, get as many different types as you can, and ideally do the assay centrally so that you can distribute data, not sample. The issue of data inaccessibility. Data per se may not be helpful. Imaging data means nothing to me. Turning those data at scale into accessible information that all kinds of researchers can use is going to be the key about accessibility. And then we've touched on this earlier, the issue around insufficient specificity of the disease outcomes. If what we give to people to use is really very poorly detailed disease outcomes, then either that won't be useful to them, or they're going to have to spend a lot of time doing work to make the data useful for them. You need to reduce the hurdles to access. So this is what has happened in terms of use. We've had 1,612 researchers around the world have registered. 277 have put in preliminary applications. But the thing I wanted to point out to you, for a resource that's available for anyone to use anywhere in the world, we clearly misnamed this project and should have called it International Biobank because it's not being used outside of the UK, largely, and it's certainly not being used in the US. Now, what might be the reasons for that? Perhaps a lack of belief in the access principles. If it sounds too good to be true, they always say it could be. But alternatively, it may be that the academic return for being involved in this is you know the data. You've helped to get it built the way you want it to be built. and therefore you tend to use it. So the people who help make it happen may be the ones who get the early benefit from having invested in the resource. Thank you.
Thank you, Roy.